Hello, your host, and welcome to Fertility Fact or Fiction, our weekly show where we bring you the latest and greatest in infertility and help you make your journey a more successful journey and hopefully a cheaper one too. I am a Canadian trained obstetrician gynecologist with American Board subspecialty training and licensure and certification. And we are going to be presenting tonight on a super cool topic, which is whether or not you should have a fresh or a frozen embryo transfer for endometriosis if you have endometriosis. So very interesting topic. There's obviously lots of opinions on this, but this is interesting because it's actually a meta-analysis of the available studies. And so this should be very, very interesting for all of you out there, especially if you're suffering from endo. We certainly know that a lot of people with endo have fertility struggles to begin with. The last thing you want to do is make it even worse with the IVF procedure because now you're really putting in all of your emotion, your time, your energy, and your finances into giving you your best possible chance. And so we want to make sure that it is your best possible chance. So we are obviously looking always for new information on this and wanting to make sure that we can find information that is valuable to you so that you can advocate for yourself and make your journey more successful. So let's just begin by talking a little bit about what endometriosis is. We'll go over how it kind of affects fertility, and then we can talk about whether or not this study shows that fresh or frozen transfer is better. So endometriosis is a condition where the cells from inside the lining of your uterus, the stuff that typically sheds with your period, magically finds its way to places where it does not belong. So those places would be things like on the surface of your uterus, it may be on your fallopian tubes, in your ovary or on your ovaries, on the pelvic side wall, the bladder, the bowel, pretty much anywhere. You can even find it in really distant sites like the diaphragm, the brain, and the lungs, and so on. So these cells are still alive and they are still hormonally reactive, meaning that if you are still producing your regular hormones, estrogen and progesterone, these cells are going to grow and retract and grow and retract in response to the estrogen and the progesterone. So the reason endometriosis patients get pain is because the estrogen makes those cells grow. Your immune system recognizes they're not supposed to be there. It tries to attack them to kill them and get rid of them, and that causes a whole host of pain responses. Not to mention you can get some adhesions where one thing sticks to another because, again, the cells are not supposed to be there, and all that inflammation and reaction from your immune system makes the tissue sticky. So when you put two sticky things next to each other, they're going to stick together, and now you've got scarring and damage to the organ structures inside you. All of this immune reactivity is obviously thought to be bad for infertility patients because embryos like a nice, happy, kind of chill environment to get into, and they don't want to go into somewhere where there's already an immune war being waged. So the question is, what happens when you go through IVF? Well, in an IVF cycle, unless you're doing a pure natural IVF cycle with only one egg, you're typically going to produce estrogen levels that are way above the normal. So what's happening to your endo? Well, even in a natural IVF cycle, your endometriosis is seeing the estrogen with the estrogen rise in the follicular phase of your cycle. That estrogen feeds the endometriosis, and the endometriosis becomes more active. That in turn triggers your immune system. If you have multiple eggs, you're just kind of pouring fuel on the fire because you're making that endometriosis that much worse because now it has extra estrogen to feed on compared to what it would be like with the natural cycle. So of course, people have said, does it make sense to do a fresh embryo transfer when you're doing IVF? So you do your IVF cycle, you grow your embryos, and you put them in immediately with no freezing of the embryos first. Or does it make sense to do a frozen embryo transfer where you allow the patient time to get the estrogen levels back down, and then you go ahead and you do the embryo transfer? So we here on the show have for years advocated for the fact that it literally makes absolutely no sense to do a fresh embryo transfer because we know that with those high estrogen levels, you are driving the endometriosis to be active. That in turn is activating your immune system. The whole thing is anti-fertility from beginning to end, and so it's not going to be beneficial. But there wasn't really a ton of proof, just individual level studies. So here, and we're going to do some screen sharing in a moment, here you'll be able to see that there is the ability from this study to determine, is this useful or not? So I'm going to pull up the study for you. It's from a Chinese group where they analyzed all of the available studies and did something called a systematic review and meta-analysis. So the study is entitled Association of Embryo Transfer Type with Infertility and Endometriosis, a Systematic Review and Meta-Analysis. We are up on the screen now. So it's going to be published shortly. It was online March 24th as a pre-print, and it's going to be available in the print form shortly. So this is kind of advanced assessment. So I'm going to just expand this part to show you. They started with 919 identified records, so this huge number of studies. They took those studies and they assessed which ones were really valid and which ones were not. They were able to bring it down to 603 studies that they thought were worthy of screening. From that, they said that a whole bunch of them needed to be excluded after they read the title and the abstract, so they got down to 309. And then from 309, they ended up with only 6 studies, which actually met their strict criteria. The good news, it's strict data. It's narrowed down to exactly what we need. The bad news, you went from 919 down to 6 studies. So obviously we would like more, not less. The more data you have, the stronger the response that you get. So what did they end up with? They ended up with the 6 studies, which included a total of 3,010 women with endometriosis who were trying to conceive. 1,777 had frozen embryo transfers, 1,233 had fresh embryo transfers. So the majority of them talked about the different outcomes like live birth, clinical pregnancy, and miscarriage. So on this slide, I've kind of highlighted for you the important findings. So the very first one is live birth. This is called the forest plot. So they put all the studies together, they analyze where the outcome is, and then they look to see if it's significant. So I'm just going to expand this part for you if I can for a second. You'll see it there. So you can see where I've highlighted it. It says 1.53, and that diamond shape is to the right of the line for the odds ratio of 1. So the 1.53 means those patients had a 53% increase in live birth rate. Which group is that? It's the frozen embryo transfer group. So a huge increase in live birth compared to the group that had the fresh embryo transfer. So much more live birth chance with a frozen embryo transfer than with a fresh. Makes perfect sense because obviously, like I said before, you're not getting those super high estrogen levels, you're keeping it low. The truth is, if you have an appropriate protocol between the time you do your embryo creation or egg collection and the time you do your embryo transfer, you can probably get that rate even higher because most of these patients need to get suppressive therapy or surgery, and then on top of that, they need a very low estrogen protocol when they're doing their embryo transfer. So we use letrozole for that and try and avoid any estrogen exposure, where you're keeping the estrogen levels very low, you keep the endo very quiet, you now basically normalize the patient's chances of success. And this is way better for the patient than it would be to go ahead and do a fresh embryo transfer. When they looked at the chance of clinical pregnancy, it just missed being statistically significant. So live birth was hugely impacted, but clinical pregnancy did not seem to make a difference. So some of these clinical pregnancies are going on, but then unfortunately, some of them are ending up in miscarriage. And again, if you look at the miscarriage data down here, you can see it's at 0.7. That 0.7 is to the left of the line, which means you got a 30% decrease in miscarriage rates if you had a frozen embryo transfer. Again, The theory behind this is all of that immune reactivity is setting up your immune system to take a look at the embryo and say, maybe this doesn't belong here. Maybe we should make the environment unfriendly or actually attack the embryo and thereby prevent the embryo from continuing, obviously a devastating outcome for any individual or couple out there who are trying. So it does look like there is a huge decrease in miscarriage and a huge increase in live birth by going to a frozen embryo transfer. So these are very, very, very substantial findings. So at the end of the article, they do comment on the fact that they're not sure that the data demonstrates it 100%, because when they had to pick apart individual studies, the findings were not quite as strong. But overall, they say that the evidence was considered moderate, and based on this, they do feel that they can say that you are going to get a higher live birth rate and a lower miscarriage rate by going to a frozen embryo transfer. So for us, I mean, we've talked about this forever in terms of what the appropriate, strategies were here. And the answer is, there's no question that biologically, anybody doing a fresh embryo transfer in someone with endo, especially when they have a relatively high number of eggs, is just biologically, not on solid ground. You've got very high estrogen levels. It's literally just pouring fuel on the endometriosis fire. There isn't a worse time to transfer in an embryo than at that point. So I cannot understand or fathom whatsoever why anybody would choose to do that. Now, many of you are probably saying, well, my center transferred us fresh. I genuinely cannot understand why. We never let our endo patients transfer fresh unless they're in natural cycle embryo collection and creation. So natural cycle IVF, you can definitely go ahead and do a fresh transfer because you haven't really stimulated the endo that much. It's still probably better to do freezing suppression and or surgery and then use the letrozole protocol, but your estrogen levels are not really going any higher than they naturally would. So it's a reasonable option to consider. But if you've made 3, 4, 5, 10, 15 eggs, you definitely need to get a frozen embryo transfer. So it's a real quick and easy fertility fact or fiction tonight. It is a fact. A frozen embryo transfer is the only way to go when you have significant endometriosis. One of our readers asked whether or not they analyzed the severity of the endometriosis, and that was only the case in one study. So there isn't enough data from all of this in order to be able to tell you that. But undoubtedly, the worse the endo is, the more significant the impact is going to be on the fresh versus the frozen, up until a point where there's so much damage that it actually probably doesn't make a lot of difference. There's still this chronic inflammation there. So that's probably the biology behind it. So for those of you who are stage 4, I would definitely recommend suppression because you need that. But if you're doing a natural cycle, do you still need the suppression versus just going ahead? There probably isn't going to be a huge difference in those cases. But for everybody else, stage 1, stage 2, stage 3s, you really strongly should consider moving to a frozen embryo transfer because that will improve your outcomes. So thank you for joining us for Fertility Fact or Fiction. Make sure you watch us on YouTube or Instagram. Click that follow or subscribe button. And if you have questions or comments, just pop them in there and we will definitely address them at the earliest opportunity that we can. And now, as usual, we're going to flip over to our next segment where we take your questions live.
How do you time a frozen embryo transfer?
A frozen embryo transfer can be timed one of two ways. You can do a stimulated cycle where we're giving you medications and hormones and so on, in which case we have the luxury of being able to time it for basically whenever your body is ready. Or you can have a natural cycle where it has to be timed to your LH surge. If it's timed to the LH surge, it has to be day 5, 6, or 7 after the surge. They actually recently studied it and showed that there was no difference in the success rates regardless of whether you did day 5, 6, or 7, but most people will do LH plus 7. If you're doing a stimulated cycle, we're really just waiting for your lining to develop into a thick enough lining to be appropriate, and then you start the progesterone. Day 5 embryos should be transferred after 5 days of progesterone, and day 6 embryos after 6 days of progesterone. So it's pretty easy to time it. It just depends on which mode or which protocol you're using to go forwards.
Hello, Dr. V. I'm doing my egg retrieval with you next month. What is the wait time for egg retrieval to frozen transfer day?
In general, you're probably looking at about 1 to 2 months. There are some circumstances that will alter that, like endometriosis, as we just discussed, but generally speaking, 1 to 2 months is satisfactory.
Hi, Dr. V. How long after the last Lupron depot shot do you start transfer protocol? My last shot was July 15.
We will start your transfer protocol right off of your Lupron shot if you're on depot Lupron. So we use Lupron and letrozole for 3 months, and then you just extend the letrozole for an extra 5 days after the 12 weeks that the Lupron is good, and then an egg will usually grow. So then you just watch an egg grow and you watch the lining develop, and then you can go ahead from there.
Hi, Dr. V and T. Dr. V, do you feel the benefits of treating borderline high NKA cell activity outweighs the risks? 10.5%.
Not if you haven't had a previous failure, but it depends on how many embryos you have. So if you have lots of embryos and you're willing to risk 1 or 2, yeah, I'd probably go ahead and try without treating the NK activity. But if you only have 1 or 2 embryos, then I would probably treat the NK activity, because you don't want to put anything at risk and have to go through the whole process all over again.
Dr. V, thank you for shining a light at the end of the tunnel.
Oh, good.
I have done 5 IVFs and got only 2 euploid embryos.
Okay.
I am 44 years old with low egg quality. Could I improve quality, and which protocols to use?
So congratulations on getting 2 euploid embryos at 44. That's actually reasonably challenging. 5 IVF cycles is certainly a lot. There is no way to improve quality other than vitamins, supplements, healthy diet, no smoking, no drinking, no drug use, exercise, that kind of thing. That will improve your quality a little bit. Same things for your partner. That's also equally important. I think the important thing to understand is that it's the genetics that are the main issue, and you can't alter the genetics because they were predetermined when you were born. So your egg genetics were made long before you ever got to the point where you were going to be fertile. So you're not going to alter your egg genetics. So the ratio of normal to abnormal embryos chromosomally is not going to change no matter what you do. But you will alter the quality of the embryo you make a little bit, and it is very little, by doing the natural kind of approaches to things, the naturopathy, homeopathy, the other treatments like acupuncture, yoga possibly, stress reduction, special diets like the Mediterranean diet, exercise, and then avoiding all the bad stuff. For your partner, essentially the same things: frequent ejaculation, keeping the testicles cold, all of that will help. Tarek was having a party off screen there for a moment. Sorry about that.
Something loaded up for you. Hi, I live in NC.
North Carolina.
North Carolina.
Yeah.
Do you treat patients outside of Canada? If so, how does that work?
Yeah, we treat patients all the time. I actually spent about 2 hours on the Zoom call with some lovely folks from Colorado recently. So, and if you're watching, hi guys, you were great to talk to. So yeah, we treat patients actually from all over the world. We have a huge following in Ireland and England. Scotland is rapidly growing, Germany as well. So yeah, North Carolina is easy. We've had patients come to us from all over the United States. We're cheaper, much more patient-centric, a lot more humanitarian, and less money-focused than they are in the States. So all you have to do is contact info, I-N-F-O, at drvictory.com. Ask for a consult, and they'll arrange a 1-hour Zoom with me. It's not expensive to meet with me, and we genuinely try and go out of our way to either make your journey better where you are Or if you want to come to us, then by all means, we're happy to take you here. But we don't insist on it. I'm all about helping people. The location of where you do your IVF is less important to us than the outcome is.
Hello, Dr. V and T. Is androgel something you would prescribe to improve egg quality? 41 years old, low AMH, 0.46.
So androgel has never been shown to improve egg quality. It may increase the number of eggs you get. There is one study that showed that testosterone priming can improve live birth rates, but it was only one study. The rest of them have not shown that. So if you want to improve embryo quality, you're really looking for an increase in live birth. DHEA will do that, but you got to take it for 3 months. And there is a meta-analysis that supports that. But testosterone priming has never been shown to increase live birth rates. So we don't use testosterone, which is what androgel is, but we do use DHEA for our patients.
When is it safe to resume moderate exercise, biking, golf, jogging, following a positive beta HCG?
As long as there's no bleeding, biking's probably fine, although you're going to get saddle sore pretty quick, so it's not something we frequently recommend. And if you fall off of a bike, which you are more prone to the later you go into the pregnancy, that's not a good fall. So bike falls are always pretty bad falls. You get hurt pretty badly and very high chance of injuring your abdomen. So bikes we're not thrilled with. Treadmill, elliptical in particular, great. Swimming, wonderful. Light exercise, okay. Moderate exercise, I mean, if it's an IVF pregnancy, I'm pretty careful with my patients. I tell them no heavy lifting, no straining. Keep your heart rate under 120. But you know, everybody's different, so it depends on how athletic you are.
Hi T and V. Do you recommend 1 embryo to 2 embryo transfers for a 40-year-old? Who has more than 4 embryos? Who has greater than 4 embryos?
So for someone who's 40 who has over 4 embryos, would I transfer 1 or 2? So that's a great question. So a 40-year-old patient, she's asking if she has more than 4 embryos, should she transfer 1 or 2? So that's a multi-part question or multi-part answer. So the first question I would have is, are they genetically tested? If they're genetically tested and they're normal, I would only transfer 1 at a time. If they are not genetically tested, absolutely you could transfer 2 or realistically even 3 at a time, because the expectation is going to be pretty high that 1 or 2 of them will not be normal. So I would want to know if they're genetically tested for sure. The other thing you need to know is your history. Have you failed before? Are there any other risk factors for failure? Weight, medical conditions, sperm quality, uterine shape, fibroids, that kind of thing. And then the last thing to think about is the fact that if you have had them genetically tested, even if they are genetically normal, when you're over 40, the chance of success is much lower with a normal embryo than a normal embryo from someone that's younger, like 35. So you do need to factor in the math of what your chances are going to be before you decide 1 or 2. If you're prepared for twins, then there's certainly nothing wrong with putting in 2 at 40. But keep in mind there is a substantial risk of twins, and twins have risks for you. They have risks for the infants, especially if they come early, which they frequently do, and those risks can be very, very detrimental. And then there are risks socially because it's an 80% divorce rate if you have twins. So it's difficult for sure. So only do it if you're absolutely prepared for the offsides to it.
Repeated IVF cycle worsen endo?
Yes, every time you do an IVF cycle, your endo will worsen because your estrogen levels are going up and you're pouring fuel on that endo fire. So you want to avoid doing multiple cycles of IVF, which is why at VRC we do everything humanly possible to maximize the chances that your cycle is going to work on first cycle, not first try because we're not doing fresh transfers, but on first cycle. We only want you to succeed with 1 try. We don't want you coming back for repeat business. I'm only happy when I know it worked on the first try, and knock wood, we get most of our patients pregnant on first try. So, yeah.
Hi, Dr. V. How can
Oh, so no T and V this time,
Um,
because they acknowledged you first.
you know what? I noticed it. I noticed you laughed at it, and I was offended on it. On top of that, I noticed that made a little bit. That made a little facial expression on it.
I need to at least go first. Come on. All right.
I felt like that question was meant for me.
It was meant for you,
I felt
yeah.
like I should have answered.
Yeah. You guys can ask Tarek some questions. Let's see what his answers are. All right.
Hi, Dr. V. How can thicken my endometrial lining naturally?
We got to come up with that video, man. We really do. Okay, we got to do that sometime next week. We got to make it. Put a note down somewhere. Okay, endometrial thickening: PRP, Viagra, aspirin, vitamin C, D, and E, Neupogen. Those are the main things that work. Of course, estrogen. And if none of that's working, you need surgery to figure out if there's something wrong. Plus minus testing for infections to see if there's something wrong. Probiotics may also help. All of these things have been tested. All of these things have been shown to be beneficial. So any of those will work. So platelet-rich plasma, Neupogen, vitamin C, D, and E, Viagra can help. Aspirin will help. All of these have been proven to thicken your lining.
Could you please discuss anti-phospholipid antibodies? I have a mod high AV2 GM level at 42. Didn't realize I was being tested for this, what it means, or how to treat.
So if you have antiphospholipid antibody syndrome or antiphospholipid antibodies, the problem is that your arterial blood flow will clot more easily than somebody else. So when the placenta is, you know what, this is a draw thing. All right, we're gonna get the draw. Let me draw this out for you because it'll make more sense to all of you out there. Yeah, I will. Let me pull up the notes thing first. Okay, so share screen. There you go. Okay, so when the placenta is forming, we're locked and loaded. You good?
Go ahead, yep.
Okay, so I'm gonna draw here. Hopefully it's in black. Okay, so here is your uterus. Whoops, I went off screen there. Sorry, guys. So when, yeah, we'll go there. So when your uterus is here and your placenta is forming, we'll do the placenta in blue. So, and make it a little bit thicker. So when your placenta is forming, oh, that came out red. It's gonna come out as a, you know what, let's do that in blue actually. It's gonna come out as this thing that looks like a hamburger. And what needs to happen is blood flow needs to go through your uterus and connect to the placenta like that to supply it with blood flow. So if all of a sudden we've got little blood clots, what's happening? We're losing the blood flow just like that. You're decreasing the blood flow. And as soon as you decrease the blood flow, the placenta realizes it can't function properly and it either tears off or it dies and stops working. Unfortunately, the placenta is connected to your baby. Here's where you all realize I am not an artist. And if your placenta is not working properly, your baby's not getting blood and oxygen. So at the fetal stage, it'll terminate and it'll result in a miscarriage. So the way to avoid this is to provide a blood thinner, which prevents those blood clots from happening, because the blood clots go and they get stuck in these tiny little blood vessels in the placenta and or in the wall of the uterus, and they prevent the blood from going past the blockage. So if you keep someone on blood thinners, they're actually not going to block the blood flow. The blood flow can go back and forth much more easily, and so you avoid miscarriage. So in our practice, we always administer aspirin and low molecular weight heparin to these patients.
How thick the endometrial lining needs to be for an IUI procedure?
IUI, same as IVF, so usually somewhere between 7 to 13 or 14 millimeters. Anywhere in that range is okay for IUI.
For endo patients who do a stimulated egg retrieval, then require suppression, do you do Lupron for 3 months, and how do you manage menopausal side effects?
Well, we do Lupron and letrozole for 3 months, so that's huge. And then we also want to make sure that you are comfortable with the symptoms. How do you manage menopausal side effects? You actually can't. So for those 3 months, we tell the partners to be extra nice, do everything they can around the house, not trigger any emotional reactions, and try and let you have your peace as much as possible, because you will endure full-on menopause for 3 months, and it is not pleasant.
Is PIO better than suppositories?
Yes, unequivocally. There are multiple studies now which demonstrate the superiority of progesterone in oil to vaginal suppositories, but there are also multiple studies which show that the combo is better than either one alone. So we use both. We use the suppositories and the PIO together.
I have a very complex case and it won't let me type it at all.
DM me or email me.
There you go.
Yeah, I mean, super complex cases, just DM me on Instagram, and I do respond. I respond actually to everybody. So yeah, just DM me and I'll get back to you. We probably need a phone call or something, but we'll figure it out.
She's pending a friend request or something. In the meantime,
Yeah.
Hi, Dr. V. You mentioned 5 days of letrozole after the last Lupron depot shot. Are
Yeah.
other meds involved, such as estrogen and PIO?
So we rarely use estrogen. As much as possible, we avoid it, only if your lining is not thickening enough, and that's helping us to get spectacular success rates. We do use PIO, we use vaginal progesterone, we use all sorts of vitamins and supplements. We use antibiotics, we use probiotics, so we have like a really complex protocol, but it works like the best I've ever seen. So our protocol is amazing, very, very sophisticated. It has a lot of steps to it, but it's at the same time very elegant. It's all scientifically based, and it's giving us phenomenal success rates. So we've been very, very pleased.
Could you please be more specific about which vitamins to improve the egg quality?
Vitamin D, C, D, and E are all helpful. A prenatal, fish oils, coenzyme Q10, melatonin is helpful as well. More for egg retrieval, but it's still helpful, and for embryo transfer. Those are the main ones that we are using. Coenzyme Q10, iron as well. Sorry, I forgot that. So yeah, all the antioxidants you can get, in particular vitamin D. And then make sure that you are using the other supplements. Now, if you're PCO, we also add in things like NAC, inositol, resveratrol. And if you're endometriosis, we do NAC, coenzyme Q10, resveratrol, and curcumin. So it all depends on what your condition is. We individualize for different categories of patients, which you should always be getting.
After an embryo transfer, what type of exercise workout should be avoided?
After any embryo transfer, you should never do heavy exercise or anything like hot yoga, something where your heart rate's really high, you're having huge swings in your metabolism. That's never going to be a good thing for you. So you generally want to take it reasonably easy. I'm not telling you to become a couch potato. That's a bad idea too. But you also don't want to be training for the Tough Mudder in the middle of your embryo transfer. So appropriate exercise is fine, nothing too heavy.
Hi, Dr. V. For someone with the dermoid ovarian cyst,
Yeah.
would you recommend removing the cyst first and then start IVF, or it does not matter?
You definitely want your dermoids out before you do IVF, because if they accidentally puncture the dermoid at the time of your egg retrieval, it's a disaster. You'll need emergent surgery, and that's the worst time to do it because your ovaries are big and very vascular. And if they don't puncture it, they may not be able to get at all your eggs because of the location of the dermoid. And if you get pregnant after it with the dermoid still there, you're now running into the problem of the dermoid either rupturing or twisting the ovary, depending on how big it gets. And then if you get operated on during pregnancy, you have a huge risk of miscarriage. So that is not good or safe. Now, on the flip side, and this is super important, guys, so please, please, please focus on this one. If you're getting surgery for an ovarian cyst, you must go to a true expert who specializes actually in reproductive surgery, because they are going to be sensitive to the fact that doing this the wrong way will damage your ovary. If you are not sensitive to the manner in which the surgery is done, you will do a huge amount of damage to the ovary, and that is not a good thing. You can really end up losing half. I'll just do that screen mirroring thing again, and I can kind of show you what I mean here, because it's really important. What's that? I'm feeling artistic today, yeah. Okay, so we're going to try a new page. So if we show you, if this is your egg, okay, and you want to, and we'll do that, I'm not good at 3D, but let's say this is like 3D egg, okay? So if this is your egg, or your ovary, sorry, and you want to get a cyst out of it, your option is to kind of cut the whole thing in half, so this is going around it, and circumferentially cut the thing in half, after which you end up with your ovary looking like Pac-Man. Whoops. So it's going to look very much like this, because you've now split it in half, and then you just cut it off. You take off the upper half. The cyst is going to be here, and you can peel out the cyst, and now you only have to take it off from this half. And so it's much easier because the other half is exposed. The problem with this is you've lost all of this valuable ovarian tissue because you devascularized it and or removed it. This process is called de-roofing the ovary, because you take the roof off of the ovary. So this is what a surgical imbecile would do, and that should never be done. The proper way to do it is, here's your ovary, you make a tiny little cut, and then you gently peel it open. And just like you're opening up like almost like an orange or something, you spread this open and you scoop the inside out by gently peeling this away from the wall, so that you've only made the one little cut, and that's the only part of the ovary that's damaged. All the rest of the ovary stays intact. You got to think of this in 360 degrees. So you've made this tiny little nick, and that's how this cyst comes out. I'll probably need to put up a endometriosis video for you guys soon, but essentially that's the way this should be done. YouTube doesn't love it when we put up surgical videos, because they think it's going to scare people. So yeah, we don't put up too many of them, but that's the proper way to do that surgery. So make sure you're getting a surgeon who is just going to make a single cut, very gently peel apart the two sides, scoop out the cyst from inside, regardless of what kind of cyst it is, and then leave the ovary alone. And the most important thing after is, don't let them burn your ovary, because there's always some bleeding along the edge here, right there and there. And so what they do is they take cautery and they start burning it, because everybody's panicked it's going to bleed. If you leave the ovary alone for just like 5 minutes, it starts to contract and it stops bleeding on its own. At most, you may need to apply a chemical or something to get it to bleed, but don't burn it, because the heat damage from cautery has been proven to be detrimental to the ovary. So you never want to do that.
How does low iron impact your transfer? Any recommendations to assist?
So there is a study that shows that low iron is not a great thing for embryo transfers. Are we still sharing, or are we off of share?
You're off the share.
Okay. So yeah, so we make sure our patients' iron levels are appropriate before we transfer. Take a glycosylated iron supplement, so Ferromax, Triferix, Palifer, Eurofer, those are the ones I know. I don't care which one you use, but they're all really good.
Do you recommend patients stop breastfeeding for SPT?
I would never allow my patient to try a transfer while they're breastfeeding. That would be maniacal. You have to stop breastfeeding, because your prolactin levels will be high. Even if they're not elevated in your blood test, they're functionally elevated. That's going to interfere with your lining quality. You cannot try to get pregnant while you're breastfeeding. It's a mistake for sure.
Do you think daily 250 IU HCG boosters are helpful after an embryo transfer?
No, it's been studied and proven to not be useful, so don't bother with that. There are multiple trials which have shown that that is not beneficial.
Do you suggest Neupogen or Omnitrope for priming prior to frozen embryo transfer?
So both have actually been shown to improve your frozen embryo transfer rates. Neupogen can, although it's more beneficial by injecting it into the uterus or culturing the embryos in it. The injections, I'm less familiar with the data that says that Neupogen injections can help with frozen embryo transfer. These are like subcutaneous injections. But Omnitrope or human growth hormone actually has been shown to improve the outcomes with frozen embryo transfers, so that can be considered. They see alterations in your endometrial blood flow. It's another agent that can be considered to thicken your lining. We don't use it often, but it's doable.
I have unexplained recurrent loss.
Oh, sorry.
Would asking to be checked for endometriosis be helpful? What procedure would be needed to check this?
So if you have unexplained recurrent loss, you need a very thorough workup, and not just you, your partner does as well. We don't normally go looking for endometriosis, although there are studies that support the idea that endo leads to a higher risk of miscarriage, but it's just not something common for us to explore for those patients. But you do need a very thorough workup, and quite frankly, most centers and most physicians don't do it because they just want you to keep doing more IVF. I'm a total non-believer in that. I actually like having my answers first so that I can help you rather than just torturing you with doing more and more and more cycles of IVF. So for us, we want to make sure we know what's wrong, and then we want to fix what's wrong. So that's our approach to things.
Do you recommend Emma Alice after one failed euploid transfer with endometriosis?
Well, first I'd want to know what your transfer protocol was. I don't use Emma and Alice, but we do use Fertility. So if you're going to do Fertility, sure. And I'm just not a huge fan of Emma and Alice, but they're reasonable tests. More importantly, I think I would want to know your transfer protocol. If they gave you a whole bunch of estrogen supplementation to get your lining ready, they fueled the fire of your endo, that's not going to work. So you need to have a low estrogen protocol when you were doing a frozen embryo transfer for endo.
How can I reduce overheating of body a few days post-ovulation? Currently on prednisone, heparin, SCIG, 3 previous miscarriages, worried immune system is overdrive. Thanks.
Well, you're on a bunch of stuff that should be suppressing your immune system, so it's unlikely it's in overdrive. I would check your thyroid levels if you're worried about body heat, but I mean, short of keeping yourself cool, there actually isn't a way to alter your body's temperature. Your naturopath or a traditional Chinese medicine specialist may have more luck with that. I don't know this for a fact, but I would be shocked if they couldn't manipulate your body temp with something like acupuncture. So I would speak to someone like that. We as Western docs, even though I probably have more knowledge than most in that area, don't know enough about that to be able to guide you properly. Cupping?
No, yeah, sure. That's my advice.
I don't know. Well, cupping would probably increase your body temperature. Yeah. Oh, you mean acupuncture needles? I don't know. I'm not tapping any into my temple, dude. That's not a good idea. Do not listen to Tarek's suggestion on that one. No acupuncture needles in your head.
Hey, T&V.
Did you look for that one? Like, where was that just, I'm going to sock it to?
Should we just leave it right there? I think that's good.
No, let them have their question.
Okay. FU, 40 years, 0 genetically tested, 2 low mosaic and high mosaic, second round of IVF, will not be tested. I have all goods other than that.
What? Let me see that. What does it say?
It definitely says Hey T.
Where is it?
Right here.
Okay. Hey TMV. Follow up. 40. Oh, for the 40-year-old.
Yeah.
Because when you said FU, I thought you were swearing at me.
Oh, no.
Okay, so genetically tested 2, low mosaic and high mosaic. Second round of infertility will not be tested. I have all good other that. Okay, so low-level mosaics are reasonable. They give you a 50-50 chance. High-level mosaics are really not very reasonable. At 40, in my opinion, you should be testing because the balance of the risk-benefit ratio is in favor of PGT testing, because we know that probably around 80% of your embryos will not be genetically normal. And if you don't know, you're just putting in embryo after embryo without knowing if they're good or not. So we would advocate for testing over 40.
How do you manage free fluid in the uterus with no tubal issues or hydrostatics?
Oh, so that's a great question. Free fluid in the uterus, if you have no hydrosalpinx and no tubal issues, is usually from your cesarean section scar. So if you have an isthmosial defect, here we're going again back to drawing. Screen share?
This is amazing.
I know, it's like art night. Oh, I'm still connected. Yeah, okay, so here's your uterus. I'll go this way. Pen. Okay, so, oh, it didn't work. What happened? Okay.
Drawing.
I know. There we go. So here's your uterus. So normal uterus, it looks like this on the inside. But if you have an isthmosial, what you actually get is this. So it looks like a shark. And this part here tends to fill with blood, old blood, and that old blood causes fluid to accumulate in your uterus, and so now you've got all this fluid going on in the uterus. So what do? You get somebody to either remove or burn this whole segment here so that it can't produce blood or trap fluid anymore, and that will end up helping you to reduce the fluid in the uterus. The other thing you do, you look for infections inside the uterus, because that's also a likely source of where the fluid's coming from. That's as good as it's going to get. If you still have fluid there, I never advocate for transferring because it will not work. You're basically putting your embryo on top of the wave. Here's your, we'll do it in green. Here's your lovely little embryo. The uterus contracts all the time. It's a directional contraction. It's going to shoot the embryo right out as it rides from wave to wave to wave to wave and then leaves your body. So don't put fluid in there. I don't put embryos in there if there's fluid. There's my very colorful picture.
Best picture so far. How does sleep apnea affect the outcome of an embryo transfer?
It's a disaster. People with sleep apnea have lower oxygen. They're failing to supply oxygen. Weight is often, if not always, an issue. That's a problem as well independently. Their blood pressure tends to be higher, and that's also a problem. And people with sleep apnea have a much higher risk of complication in pregnancy, including stillbirth, preeclampsia, hypertension, and so on. So you definitely need to deal with your sleep apnea before going into an embryo transfer. That is critical.
I thought I saw another Haiti.
You realize it's just the alphabetical order. You come,
No way.
T comes
That is not
before B.
They enjoy my commentary and banter. No, they know.
They know it's you, eh?
They know.
They're going with the T. You guys are going with T first? I totally feel betrayed here.
No, don't worry. They know I can't answer half of these.
Just half.
You know what? Question for T. I skipped every question and I went just to this one. Question for T.
Okay.
Would you please show us your face, which I am sure is camera worthy, and give us your best fertility tips? That's for another day. I didn't read it out. I read it out loud.
T is forever going to be a mystery. We're going to keep him like quiet and secret. So we'll bring him on someday.
Fertility tips I could probably offer
Someday.
some, to be honest.
How about we work on getting to, I don't know, let's get to 10,000 YouTube watchers and then, or followers, and then we'll consider showing T.
I think it's a worthy
Best way to reward T is to follow us and like our posts and our various social media accounts.
I think it's very reasonable.
There you go.
I had my hi Dr. Victory. This is just for you. Sir.
This one's just for me. Okay.
I had my FET Friday.
Yeah.
I've been having clusters of cramping in the lower abdomen pelvic area, almost like pinching. Is this concerning?
I mean, I would only be worried if there was a concern regarding infection, if your transfer was really difficult or something like that, but otherwise, no, it wouldn't be concerning. Also, make sure you're not infected in your urine. But all sorts of people get all sorts of symptoms after an embryo transfer. Make sure your estrogen levels aren't too high. If your estrogen levels are really high, it may be a side effect of that, especially if you have endo. So there are some things to look at. Talk to your RE and make sure that you're okay. If we're your RE, I don't use high estrogen levels, so I doubt that that would be a problem. But certainly reach out to us and we'll make sure we know what's going on.
What treatments do you have for severe endometriosis if you are trying naturally?
Well, we have a whole video on natural treatments for endometriosis. There are only supplements that you can do if you're trying naturally. So it's NAC, which is N-acetylcysteine, coenzyme Q10, curcumin, and resveratrol. Those are the ones we use, but we have a whole video on it, so just check out the YouTube video. Tarek will pop a link up there when this one hopefully comes out eventually. So you could probably even find it now, but there is a natural treatments for endometriosis video. Where is my YouTube app? I could probably find it on here while you do the next question.
You had recommended Flagyl 500 milligrams 3 times a day based on my fertility results. My dog gave it to me and that dose for only 1 week. He gave me a second prescription for 6 weeks of suppositories. Thoughts?
Not enough. Getting rid of infections in your uterus is virtually impossible. Fertility themselves recommends 2 weeks. I actually recommend 4. Even at 4 weeks, we have frequent cases where we have not yet gotten rid of all the anaerobic bacteria with 4 weeks of Flagyl treatment. So what you're mentioning is just, it's simply not enough. You need more.
LOL, I was offended by it. She's referring to my comment about Dr. P. Some good banter today. What does it mean?
Look at the picture that you posted on our YouTube
That's
video.
why it just took a screenshot of it now. That's you this exact second.
That's awesome. I love it. That is too
That's
funny.
your artwork, sir. That's as good as it gets.
I love it. That's really funny.
What does it mean when liver enzymes are high? Any relations to implantation failure?
Liver enzymes being high would be a very significant concern for liver infection or liver dysfunction. You should not be doing anything until you figure that out, because you cannot get pregnant with liver damage. So you need to know if you have hepatitis, if it's a HIV manifestation, if there's a drug reaction, if there's an alcohol reaction, if it's fatty liver disease. You definitely need to get that checked out. That is not a simple, straightforward kind of thing. Here is our natural endometriosis video. Do you want to just, can I screen share again?
Yeah, give me a second.
Oh, I'm already
You're screen sharing.
Yeah.
Okay, here we go.
So third row down, third tab in. It's got me looking sideways at what I think is a pineapple. So it says natural endometriosis treatments that actually work. That's the title of that one. So check that out if you want to know about natural stuff for endometriosis. Yeah. Oh, I shut off.
Dr. V, ethically speaking, could you guide the FET protocol when I would need to be monitored at a different office and the embryo is at a different lab?
Listen, ethically speaking, you can do whatever you want. It's your embryo and your cycle. You may find that there's resistance to you doing that, in which case you may need to transfer to us. But by all means, I'm happy helping you any way I can. We have loads of people that take our protocol and use it at their centers, so that's perfectly fine. I don't mind at all. I'm happy to help you.
You know, suddenly, no T's, just Dr. V. I think we're finding your fans. That's fine. For those people, let them know it's fine.
Do you want some Kleenex, buddy?
I'll manage this one. But these people next week, they're not going to get their questions
They're
asked.
not going to get their questions asked. Oh, that's funny.
Hi, Dr. V! Exclamation mark. It's
Excellent.
done.
Yeah.
Finally.
I'm back in. I'm first place again. I'm back in first.
You
Okay.
deserve it. Finally got my intimacy repaired via hysteroscopy. Surgeon says uterus looks great.
Awesome.
Would you test for anything else before transferring? Could the niche have caused inflammation or damage?
Yeah, I mean, frequently because old blood collects there. Old blood is a great nidus for infection. So I am kind of in support of doing some kind of intrauterine infection test, whether you want to do Emma Alice or Fertility. That's up to you, but I would definitely recommend that. Yeah. Yep. It's a great question.
Hi, Dr. Victory.
Okay. I'm getting a dirty look from Tariq.
You jinxed the whole thing, man. I have stage 4 endo.
Oh, I'm sorry.
And had extensive surgery for excision in 2019.
Okay.
And unsuccessful to conceive naturally.
Okay.
I'm 34 years old and have a low AMH, 1.9 picomoles per liter.
Okay.
What protocol do you follow?
Whoa. Okay, ready? So first of all, lots of supplements, the 4 I mentioned earlier: curcumin, NAC, coenzyme Q10, and resveratrol. And I'd stay on those the whole time. I would either do a natural cycle IVF cycle for you, or a microdose flare with just low to medium doses, because giving you tons of meds is just going to activate your endo and not make you any better. And not also make you any more eggs. I would get the eggs that we could. I would turn them into embryos. I would freeze for sure. Then we would give you 3 months of Lupron and letrozole. And then we would go ahead and do your embryo transfer with a minimum of estrogen, essentially a letrozole protocol, lots of supplements again, lots of vitamins, antibiotic, probiotic, steroids, possibly intralipids, depending on what you wanted to do. And then we would go from there. So that would be my protocol for you. That's assuming you want to use your eggs. Keep in mind that at the AMH level you are quoting, unfortunately, even at 34 years of age, it will be challenging to get you pregnant. It is not impossible. We would be fully supportive of helping you, but keep in mind it will be challenging and difficult. But you need a very sophisticated protocol. Garden variety IVF just does not work for those patients unless you do it over and over and over and over and over again, and then you're just getting lucky.
I live in London, Ontario.
Oh, hey.
If I transfer to your clinic, would I need to drive to Sarnia for cycle monitoring, or can that be done at Life Labs or elsewhere?
Yeah, so cycle monitoring we would probably have you do either at Create or London Health Sciences or one of the other fertility centers there, and we may be opening up an office in London sometime in the not too distant future. But otherwise, yes, you could go to Sarnia. The difference is if you're doing it outside of one of our VRC locations, there may be an extra charge if we're being charged. So if it's something OHIP covered, obviously we don't charge you, but if it's private, whatever they charge you, you just pay. We don't charge you anything extra on top of that.
I have had a cauterization of my endometriosis in October of 2021.
Okay.
I am doing egg retrieval in July.
Okay.
How would you know if
it's
I require another surgery of cautery for endo before frozen transfer?
Yeah, I would not do another surgery. I would just do suppressive treatment with the Lupron and the letrozole. It should be sufficient if you're that close to the time. 1 minute.
1 minute.
Is there a lot of questions tonight? A lot.
Probably they're not going to get answered if they have to stop.
Fire away.
Maybe I'll pick from
a TMV question.
No, but this one seems important.
Okay.
They're all important for all the viewers, just to be fair.
That's right.
Yeah. Does Hashimoto's autoimmune disease automatically translate into implantation failure issues?
Well, not automatically. It's not 100%, but there is an increased risk of failed implantation and an increased risk of miscarriage. So it's not 100% by any means, but it's like a 2.2-fold increased risk of miscarriage and failure. So yeah, we want to treat that aggressively.
Would you cancel IUIs under 7 millimeters, if not only 5 to 6 millimeters? How many IUIs at 36, 37 would you recommend before an IVF?
Would I cancel? No, because you've got 5 days basically from the time of the IUI to thicken the lining, and that's perfect time to give the patient estrogen. So we would rarely cancel. In terms of how many, there's a very good Chinese study we reviewed on the show. What's that one called? How many is too many, I think, right? How many is too many on our YouTube channel. So if you're at 36, 37, 6 is the maximum number. After 6, you should switch to IVF. I don't necessarily tell people to do 6 IUI. We find after 3, most people are fed up and they want to move on. But you can do up to 6 and expect a reasonable outcome.
Hi T and Dr. V. What dose of PIO do you typically use? Daily or Q3 days, as soon as some clinics in the US when I combo with PV progesterone?
Yeah, we still are going every day unless the patients complain too much, and then we go once every 3 days. That's from a study performed by Shady Grove, where they showed there was no difference in outcome between every day and once every 3 days. We use 50 milligrams once a day, and that's our starting dose, but we do monitor progesterone levels and frequently will adjust up and down. I had one patient on 6.25 milligrams last month because her progesterone level was too high and we had to drop it way down. So we're very careful about our dosing regimen.
Today's
One
lining,
more?
Yeah, okay. Today's lining was 5 millimeters, and this looks like a involuntary cycle. Can bleeding be because of this? Anything I should do for the next cycle?
I need way more information than that. I don't even know what we're talking about. So sorry, but that one's kind of tough to answer. 5 millimeters would be too thin. If you started to bleed, then you probably released an egg recently, so the cycle dynamics may be screwed up, but I'm not quite sure what you're asking, so my apologies. Last one. Last one. Okay, this is a good one. All right.
It's simple though.
It's simple? All right,
Yeah.
good.
I could
Simple's
have
good.
answered it, but I'll let you answer.
All right, maybe they want to hear your answer.
Nah.
Go for
Dr.
it.
V,
Okay.
are you a reproductive endocrinologist?
I am a reproductive endocrinology and infertility specialist. I am board certified in Canada and the US. So yes, I passed all my exams. I've done everything I need to. So yeah. Yep. Okay, that was a good one. Yeah, that's a good one to end on. Okay, yeah, you would think 17 years of post-high school training is enough. So listen, thank you for watching our show. Thank you for asking all your wonderful questions. I hope this was helpful for you guys. If you need more help from us, don't hesitate to reach out. It's info@drvictory.com. If you like this video, make sure you click that like button, comment for sure, and make sure you follow and tell your friends to follow too. Have a great night, guys. We'll see you next week on Fertility.